I wish I could be there with you in person. It is such an honor to join you at this conference. I know many of the other speakers, many of the invitees. I hope you've all had safe journeys. And I can tell you from snowy Wisconsin, I hope you're enjoying that wonderful sunshine that hopefully you're having there in the Carolinas. So, well, thank you again for the invitation today. My name is Amy Kind. I serve as the Associate Dean for Social Health Sciences and Programs here at the University of Wisconsin School of Medicine and Public Health. And I have the wonderful honor of getting to share with you some of our work on exposome, especially social exposome study in the setting of Alzheimer's disease. And we will spend a little bit of time talking about how the exposome has been harnessed within the policy space. This is an area that's moving forward extremely rapidly, especially some of the policy changes. In fact, some of the information I'll be sharing with you is just a few weeks old, but hopefully this will give you a very quick sense of how this field is evolving very rapidly and hopefully trigger some questions for discussion. So without further ado, I'll go ahead and begin then. Of course, you heard Dr. Hill present in the morning, and I wouldn't be a good NIA health disparities talk without highlighting the Mechanistic Health Disparities Framework by Dr. Hill and colleagues, published in 2015 in Ethnicity and Disease. This model has been fundamental for helping us understand the different factors that come together across a life course to produce health and disease in different populations. And when we think about this model, we can simplify it in looking at the main categories, and we can think about health disparities as coming about by environmental, sociocultural, behavioral, and biological factors that interact with each other across a life course to produce either wellness or disease. And of course, many of these elements are external to the biological human. So we can think of these elements as the exposome, which is the measure, the quantification of all of the exposures of an individual in a lifetime and how those exposures relate to health. This construct first comes from the field of environmental exposure, but can be applied to health disparities, to social factors, and a whole host of other items, as I'll show you in a moment. So as I mentioned, the exposome are factors that are external to the biological human. They include things such as ecosystems, social factors, including structural and inequities and structural racism, physical and chemical exposures. So think of lead in the water in Flint, Michigan, for instance, and different lifestyle exposures. These are very, very diverse factors, and they can range from the microbiome all the way to the structural inequity factors that we talked about. In fact, increasingly, it is seen that these factors interrelate with each other in some very complex ways, and then interact with the biology of the human to lead to differences in a whole host of outcomes, including neurodegenerative disorders. When we think about examining the exposome, we can think about it in three different steps. The first is quantifying exposures. So how do you bundle up these external exposures across a life course in a quantified manner in order to study them, to weight them, to understand dosage and timing? Then how do you link these types of exposures to fundamental biology to start to unlock some of the different mechanisms of disease that exist across these multidimensional spectrums? And then finally, and perhaps most importantly, the exposome provides a rapid pathway of this research to move into the action sphere. In fact, there are a number of new federal and state policies that have launched, just some in the last few weeks, some in the last 6 months, that directly use these exposome approaches in order to target resources to areas that need them most. But to start first in the quantification of exposures. So there are entire disciplines, entire fields designed to quantify these types of exposures. We can think about our colleagues in the microbiome space. We can think about many of the wonderful social scientists that carry work forward in multiple different ways, our environmental scientists, many, many others. But for the purposes of this very brief presentation, I'm going to highlight one area and then carry it through in the rest of the talk. And this is the Area Deprivation Index, or ADI. This is a metric that our team has been building now for almost 20 years. It is a very precise geospatial metric that combines 17 different measures of the social determinants of health across very small population-sensitive areas called census block groups. So a census block group in a place like an inner city can be just a physical block. It involves about 3,000 persons, but in a rural area, it may be an entire county or even larger in order to encompass that same population area. So they do vary in their geography. These census block groups also are defined every 10 years by the US Census. They lead into voting districts. They determine how many individuals come into Congress for a particular state. So the boundaries of these things are of great interest to many, many different groups. But for the purpose of this type of research, we use them to understand the populations, the full populations that live within those areas, the full populations that census captures from children all the way up to older adults. We can take these metrics of housing quality, income, education, and employment, and then pull them together through factor analysis into these ADI scores. These scores are ranked then either across a single state or across a country. We can rank them in different ways or across different cohorts, but the most standard approach is to use population-based ranking. So we anchor to the grounded US Census. So the ADI is a population-grounded metric. It is not grounded to a research cohort. It is not grounded to a selected sample other than what the census captures. It is grounded to the full US Census detected population. It is also time concordant in that we can build these metrics going back in time all the way to 1910. But going forward, we build them annually for the purpose of policy using the American Community Survey 5-year estimates and the 10-year decennial census. The current ADI measures for the full US are available through the Neighborhood Atlas, and I'll give you a brief overview of that tool at the end. But these types of metrics are also, they use statistics and approaches that are harmonizable internationally. The World Health Organization, many countries within Europe, countries within Africa, Mexico, Canada, Australia, the list goes on, use measures very, very similar to the ADI that pull together social determinants of health in similar statistical manners, sometimes at even more precise geo areas, but ultimately it allows for harmonizability in cross-national comparison. And it is a disparities-aligned US Exposome metric in that the ADI grounds very tightly to historical and current practices of redlining, particularly in many urban areas in the United States. So on this map, this happens to be an entire county within the state of Wisconsin. This is Milwaukee County, showing the urban area in the county. Many of the traditional rankings, when we think about these types of metrics, are at the county level. So this whole county would be noted as highly challenged by those rankings because of the different scores coming together and averaging. However, when we look at this much more precise geo level, we see a marked difference across Milwaukee County. So the red areas on this map are highest ADI. These are the areas that score as the most disadvantaged. The blue areas are the least disadvantaged or lowest ADI. And the first thing you see when you look at this county is that it contains some of the most challenged neighborhoods within the state of Wisconsin, but also some of the richest. And so by using this type of very precise geo level, we can pinpoint exposures in a way that allows us to move beyond the larger geographies. These metrics have been provided by our team to the research community for years for free. They have been linked now to a whole host of biological health outcomes, everything from epigenetic age acceleration, which now has been duplicated, and this finding has been echoed in multiple countries now across the globe. This idea that individuals who are living within these high ADI or highly disadvantaged neighborhoods are aging more quickly. We also see higher rates of rehospitalization and costs of care, more difficulty accessing care and services, individuals receiving poor quality care. In some work done in collaboration with Sharon Inouye out of Harvard, showing marked increased risk of postoperative delirium after elective surgery. Increased cardiovascular risk out of another Harvard-based study. And then in collaboration with Tom Gilling colleagues out of Yale, showing out of their functional study, the PEP study, which has been followed for many, many years, that individuals who are living in these higher ADI neighborhoods not only lived shorter lives, but they had more functional disability in those last years of life. They needed more nursing home care, more in-home care, and ultimately had this decreased active life expectancy. But the list can go on and on. There's thousands of publications now, hundreds if not thousands of groups that are using these metrics, and they are available to you. I do like to highlight this paper, which was published out of Amal Trivedi's group out of Brown, which shows one way that the ADI can be used in collaboration or in coordination with other individual level markers of, in this case, race and ethnicity. So this is a study that looked at Medicare Advantage plans across the country, individuals within those Medicare Advantage plans and how well their cholesterol was controlled. So on the upright axis of this graph, better is higher. So we want more cholesterol control. So we would like ideally for all of these lines to be at 100%. But as you see, not all those lines are. Across this graph, on the horizontal axis, we have from the least disadvantaged neighborhoods to the most disadvantaged neighborhoods. And then each of the lines in this graph denotes a different self-identified race and ethnicity. So just to walk us through Dr. Trivedi's group's findings here, first of all, we see that overall across groups, regardless of individual identity, individuals who are residing in the least disadvantaged neighborhoods, the lowest ADI neighborhoods, tended to have best cholesterol control. And individuals who lived in the most disadvantaged neighborhoods tended to have the worst cholesterol, the lowest cholesterol control. However, across this distribution, you also see a race difference, as these lines indicate. So individuals that identify as African American within this study, regardless of the neighborhood that they were living in, regardless of the ADI, tended to have poor cholesterol control, lower cholesterol control, when compared to their non-Hispanic, white, and full population counterparts. So this is a nice example of not only a disparity that's being seen by ADI or by neighborhood of residents, but a disparity that's existing across different race and ethnicity categories. And when we think about this and when we dive deeper, we can think about potentially different mechanisms leading to differences across these distributions from both ADI and race. So this type of multi-level analysis, this type of consideration of the exposome in the setting of individual factors is something that can be done to start teasing apart health disparities in a way that can provide additional insights towards intervention. So moving ahead very, very quickly then, when we think about next steps, especially for the Alzheimer's field, we are very interested in linking these exposomal factors to fundamental biology. So this involves a process called social biological phenotyping, in which we can link these types of exposures like the ADI across an entire life course to fundamental biological processes. We've started to do that with cohort studies, living cohort studies across the United States. This is one example that was published in JAMA Neurology in 2020, in which a cognitively unimpaired cohort who had been followed for some time was linked to the ADI by the residential address. This first assessment was a cross-sectional linkage to ADI, so where individuals were living right now, at the time closest to the MRI measures of hippocampal volume and total brain tissue volume. And what we found is that individuals who are living in the most disadvantaged neighborhoods by ADI tended to have lower total brain tissue volume and lower hippocampal volume as compared to their counterparts who are living in the least disadvantaged neighborhoods. These differences were maintained even after adjustment for many of the different factors that we consider within the brain health space. And when we looked at mediation models to try to explain some of these differences, cardiovascular risk factors explained nearly all of the differences that we were seeing in total brain tissue volume between these two groups, which makes good sense. We know individuals who live in these more disadvantaged neighborhoods have higher rates of diabetes, higher rates of cardiovascular disease, higher rates of obesity, and are more apt to use tobacco. However, when the hippocampal volume was examined, those mediation pathways did not hold. Cardiovascular risk did not explain the differences seen. And increasingly, out of some childhood brain development and brain scanning studies that have used the ADI, there is some suggestion that some of the hippocampal volume differences that we see may be due to differences that were established in childhood and in early life. But more study is needed in this area. In addition, we were interested in looking at these factors longitudinally. So in this same cohort, we examined individuals across the time frame in which they were enrolled in the cohort. And in this case, it was over the period of 10 years. And we were interested in comparing them to themselves. So as compared to themselves when they entered the cohort, where were they 10 years later? And what we found is that the individuals who are living in these more disadvantaged contexts by ADI had more rapid degeneration, accelerated degeneration of their cortical structures, and especially in AD-affected regions as compared to their counterparts. So these individuals didn't necessarily come in with great differences in brain structure, brain volume, but continued to develop them more rapidly over time in association with living in these highly disadvantaged contexts. In addition, this these differences in brain volume were associated with subtle differences in cognition, which you're seeing in these downward sloping graphs here in the tiled panels. But within the Alzheimer's space, there's also great interest in linking to tissue. When we link to tissue and when we link to biorepositories, we open up the opportunity to understand how social factors and different exposures across the life course may lead to fundamental changes in cellular function, fundamental changes in the pathways that lead to amyloid and tau. But to do this has been difficult because many of our biorepositories in the Alzheimer's field are not socially characterized, or if they have any social characterization, it is somewhat limited. Now, of course, that is not true for some of the beautiful repositories and very exquisitely phenotyped samples and participants that have come through cohorts at Rush University and elsewhere. But for the most part, we have across the country, there are a large number and perhaps the majority of biorepositories do not have in-depth social characterization. So we were interested in seeing whether we could add back some social characterization to tissues that had already been collected for decedents across a very broad time span. And we partnered with the University of California, San Diego, as well as our own brain bank at the University of Wisconsin, looking at individuals who made this very, very wonderful donation of their brains with the hope to bring about a cure to Alzheimer's disease from the years of 1993 to 2016. These were individuals many times whose donations had been made before an Alzheimer's disease center was even available. They had not been followed as part of a longitudinal cohort. There really was just their tissues, but their tissues had been exquisitely phenotyped in many ways. Much was known about the biology, the physiology, the different genomics and other omics spaces. However, without that social factor characterization, it was really difficult to be able to take those next steps to understanding more about the social impacts on differences in neurodegeneration. So we took the individuals who had donated their brains, looked at their autopsy reports at the time of donation, and abstracted their addresses at the time of death. And we started there. This was our first step. We wanted to see whether we could even do this. This was primarily a feasibility study to see if any sort of linkage could be made to social factors. As I mentioned, we build these ADIs backward in time because of the census has been collected for since the 1700s. So the ADIs can be built backwards. And for this particular cohort, the oldest participant was born in 1910. So this work was published in 2020, and what we were able to primarily show is that, first of all, it was feasible. This was highly feasible. But secondly, we did see a signal in that even in this, this cohort of 2 sites, again, it's a limited cohort, living in the more disadvantaged neighborhoods by ADI decile was associated with an increased odds of AD neuropathology. And for each step up in ADI, for each increase in that disadvantaged neighborhood decile, the burden of amyloid plaques and tangles increased. This is interesting, and we were interested in whether we could take this the next step and think about these tissues from the standpoint of life course. And so this led to the neighborhood study, which was funded just a couple of years ago, just at the beginning of the COVID pandemic. And its aims are to determine the cumulative dosage and timing of neighborhood disadvantage exposure by ADI on a whole host of ADRD relevant outcomes, including cognitive function and change over time, amyloid and tau PET and MRI markers, as well as tissue-based markers of AD and other neurodegenerative diseases. This study includes 22 different sites across the United States. These are all Alzheimer's disease research centers that have joined us in this journey. It will, as it concludes, will include over 10,000 decedents who have donated their brains to science, as well as the amyloid, tau and tau PET and MRI numbers you see here. We are coordinating this work with NAC, the National Alzheimer's Coordinating Center, for participants who have data through NAC. This helps us understand more about their experiences during their life courses. And we collect these data in a couple of different ways. When we think about building life course exposome construction, using these geospatial frameworks, using living cohorts is relatively straightforward, and that involves a survey. And there's some technical aspects that do make it complicated, but ultimately it involves asking someone where they've lived across their different lifetimes, getting those addresses and historically geocoding them to link to different exposure variables like the ADI. However, for decedents, obviously survey is not possible. So what we do with the decedent cohorts for these different brain bank decedents is that we use, start with their participant address at the time of death when the donation was made, and then use public database tracing, archival, genealogical, and historical methods. We employ large teams of historians and archivists. They comb through the publicly available data. We send them to state archives for each of these decedents. They visit Sacramento, they visit all of the different state archives that tend to be in the capitals of the different states in order to find microfiche and paper-based records. And what ends up happening is we get these beautifully curated archives of each individual's lifetime. We get an understanding for every time they touch the public record. There are, of course, death certificates, birth certificates, marriage records, purchases of homes, reporting in older US Census forms, military records, and the list goes on and on. Using this approach, we can detect in at least our initial tracings over 73% of all person years. So just about every decedent we can find at least 3 addresses for, but for most people we can find almost all. And this averages out to be about 73% of person years. So this allows us to trace back someone's life course to provide a framework for linkage. But of course, as I mentioned, one of the areas for exposomal study is this research to action pathway. And that linkage to biology is really important. We're very excited. We're excited to follow it forward and see what kinds of new fundamental mechanisms of neurodegeneration can be detected. But ultimately, right now, we have health disparities, as particularly within the United States, that require attention. And this exposomal approach can allow us to link to action. So the Neighborhood Atlas is our data democratization tool that allows anyone to access the ADI. And when I say anyone, I mean truly anyone. The tool was designed for a non-research audience, and over half of our users are well outside of academia. They're community-based groups, they're governmental groups, industry groups, other non-academicians who interact with the maps, interact with the data, and are interested in using them to inform their own actions and pathways. The Atlas is meant to be very, very simple and easy to use. You can look at disadvantage from different standpoints. This is Mississippi as compared to itself, for instance. Notice the blue around Jackson and the inner city areas of challenge are high ADI. But when we compare Mississippi to the full US, you can see the unequal distribution of burden of disadvantage across the United States, with Mississippi having higher ADI scores when compared to the full US overall. So the ADI use is now extremely widespread in US federal policy. This has absolutely exploded since the COVID pandemic. The ADI started to be used to target COVID-based resources for a number of states. And since that time, it has been adopted by a large number of state and federal entities to inform resource allocation. Everything from the Society of Thoracic Surgeons to understand how equity is embraced within their practice patterns, all the way through to partnerships with EPIC and CMS. And we'll talk a little bit about why this is so novel and innovative. Because when we think about actually making an impact in this area of addressing social determinants of health, we think about these different areas: education, income, housing, social factors. It requires programming. It requires resources to support early childhood education, to support safe housing, to support social engagement. But all of these require a consistent flow of resources to sustain. Traditionally, government has been the source of those resources, or nonprofit as part of a mission-based profit. Industry less so, especially health systems and other types of industry that are often separate to these SDOH interventions. When we think about incentives to target these types of interventions, the dominant current state is legal requirements. When we think of why education is funded, for instance, it's a legal requirement. Politics and mission play a role, but market forces are relatively rare in the current state. However, with the new policies that are being adopted, what they do is they're creating economic incentives to stimulate targeted investments in social determinants of health interventions, provide an efficient match of resource to need, because we all know that resources are limited overall, and they're ensuring that they're community aligned, because the solutions to help improve disparities in Jackson, Mississippi are going to look different than they will in Detroit, Michigan. And so when we think about traditional approaches to social determinants of health, they tend to be individual level. And for those of you who are clinicians in the room, you will have seen this, or others may have seen this if you've worked in this space. It's very difficult to target these types of interventions at the individual level. It places the burden on an individual to file separate forms. And many of us have seen social workers and others, or we have our own selves have helped individuals file forms for housing, file a separate form then for food, and a separate form for Medicare, none of which are well coordinated and ultimately are all completely separate to each other, leading to inefficiencies and a burden on the individual primarily. This in of itself leads to inequity in a whole host of ways. However, when we shift to an exposome approach, an exposome philosophy, in all of these examples, incentivizing resource targeting to high ADI neighborhoods. So putting an incentive to say this business, this government group, this nonprofit gets some sort of incentive to target a high ADI neighborhood. The targeting becomes simplified because measures are immediately available for the full US, and it suddenly places the burden on the system or entity to target the need instead of the individual. Many times this is used by ADI payment adjustment to create a market incentive. So you will get more money if you target these high ADI neighborhoods. And this also incentivizes coordination across these systems to improve access. So the Centers for Medicare and Medicaid Innovation are doing just this. So this was a program that was started under the Affordable Care Act in the Obama administration, designed to advance health equity while reining in costs of care. And all of their activities need to be cost neutral. And in 2023, just in January, they launched the ACO REACH program. It has many goals, but this goal I copied straight from the CMS.gov website is to advance health equity. And so they're testing an innovative payment approach to better support care delivery and coordination for persons in underserved communities. And it requires that these health models identify underserved communities, bring their voices to the table, and measurably reduce health disparities within those communities. And they do this by using the ADI, the very same ADI that we're linking to health metrics, linking to brain health that we produce here at the University of Wisconsin. And what it says is for health systems that target those red areas on the map, individuals who are, and they care for patients that are coming from those high ADI neighborhoods, they're going to receive more money. And those monies, in order to maintain cost neutrality, will be pulled from health systems that primarily target the richer neighborhoods, those very, very blue neighborhoods. And so with this philosophy now, multiple Medicaid programs across the country are taking suit. Blue Cross Blue Shield plans, most recently within Michigan, following this direction. We've worked with investigators and health systems and state entities in Puerto Rico, in Maryland, in all of these different areas. And with this interest of exposome-based targeting of resources and understanding more about how entities can use this type of quantifiable exposome information in order to provide more effective services. So I'll stop there. I know I've gone a minute over. Sorry about that. But hopefully you've seen that the ADI is a validated measure. Individual level social factors are important, as well as these exposome factors. These metrics of neighborhood disadvantage reflect structural inequities, and the Neighborhood Atlas is free to you. Thank you to all 52 co-Is and key personnel on our neighborhood study, and especially to the National Institutes on Aging, for whom this work wouldn't be possible, and all of our team at the Center for Health Disparities Research. Thanks.
Well, thank you, Amy. Amy, this is Heather Whitson. I want to apologize as your session chair for some of the audio difficulties at the beginning. It was a very sophisticated and high-tech issue of not turning the microphone on. So, but MEDICAID is my dear friend and one of my professional heroes. That was a tour de force, and she just demonstrated the meaning of the phrase, a person who needs no introduction. So thank you, Amy. I know that we are limited on time, but do we have time for one question? I'm not hearing a no from the organizers. So Murali, you have one question?
Again, I second that. Great talk. The real question is, what is the intervention needed to reverse this, both for the current generation and for future generations? Obviously, it's not going to be immunotherapy to fix a socioeconomic driver of inequity and increased risk. Is it capped infusions? And if so, what is the clinical trial that needs to be done to prove that that economic intervention works?
So that's such a great question. And I think this is an area that, first of all, requires much, much more research. And it will be multi-stake interventional, multi-group research, because it will need to incorporate all of these different federal agencies, of course, the NIH, but when you think about some of the interventions that are required, they go well beyond the NIH. So thinking about investments in early childhood education, for instance, could be so fundamental as we think about some of these differences in late life neurodegenerative diseases. I am very hopeful that some of these economic models will stimulate market investments in a whole host of ways, so that industry groups, as well as non-industry, federal groups, state groups, community groups, and others can come together in consortium-based models to think about these important questions that you just posed. Because of course, the opportunity to think about social interventions are broad and are not things that are just of consideration to the Alzheimer's field, obviously. But in addition, the opportunity to link some of these factors as well to tissue, to understand more about whether there are fundamental differences in some of these exposures leading to Alzheimer's endpoint biology. that could also be explored. I would hate to close that door as well. So I'm a big believer in, going forward in lots of different ways. I think one of the reasons the economic models are so exciting to me is that they stimulate, they bring together many of these different factors, these different groups in a unifying way. But there is much, much work to be done. And I think the question you asked is one that many should ask and carry forward. So thank you.